which brings us to the study in which I want to present to you the long-term outcomes. I'd anticipated that there might be a question and answer period here, but I think I understand from Dr. Bowersox that I should just continue on here, and that the question and answer period will follow this portion of the presentation. So these are the long-term outcomes. Remember that the BeAT-HF trial was a two-phase trial, beginning with the pre-market phase, in which the primary endpoints at the end of 6 months of treatment with BAT included exercise capacity as measured by 6-minute hall walk, quality of life as measured by Minnesota Living with Heart Failure, improvement in functional class, and a decrease in NT-proBNP. The data from this trial allowed the FDA to approve this device for the improvement of patients with heart failure symptoms in 2019. And I believe other regulatory agencies in Europe also approved it around the same time period. In the post-market study, which is what I'm going to focus on in the next 10 or 15 minutes, we examined as a primary endpoint cardiovascular mortality and heart failure morbidity as a composite endpoint. In addition, we looked at a number of pre-specified additional endpoints, which included a hierarchical composite win ratio analysis, all-cause mortality, durability of safety, and durability of patient-centered symptoms. In total, this randomized 323 patients in which they were all analyzed as an intention to treat trial. These 323 randomized patients experienced 332 primary events over 1,036 patient years of follow-up, with a median follow-up per patient of 3.6 years. These are the baseline characteristics between BAT and control. There's no statistical difference between the two groups. And if you look at the highlighted data, this clearly demonstrates that these are characteristics typical of patients with New York Heart Association Class 3 heart failure. In addition, they had the expected number and frequency of comorbidities such as coronary disease, atrial fibrillation, and diabetes. In addition, and importantly, these were very well treated patients. I've highlighted here the GDMT, which was present at the time that patients were randomized. And remember, patients were randomized here between 2016 and 2020. So as you think about what GDMT is, and our previous speaker talking about 4 pillars, you'll notice that the 4th pillar, which is SGLT2 inhibitors, isn't included here, but it wasn't approved at the time that these patients were randomized. But if you look at ACE, ARB, and ARNI, greater than 85%, beta blockers greater than 90%, and really interestingly, if you look at ICDs, greater than 75%. So these are well-treated patients at baseline. These are the endpoints that we examined, composite endpoint of cardiovascular mortality, heart failure morbidity. We analyzed this using a negative binomial model. The heart failure events were recurrent. The cardiovascular mortality included not only deaths, but patients who went on to LVAD or heart transplant. The heart failure morbidity included both hospitalizations and emergency room visits in patients who received intravenous therapy. Let me give you the top line summary of the key evidence. Both the primary composite endpoint and the components of that endpoint were not statistically significantly different between BAT and control. However, if you look at all-cause mortality or the hierarchical win ratio, there was clearly an improvement in the BAT group. And if you look at safety, durability, and the durability of each of the symptomatic components, they were both durable in time and similar in extent throughout the study period. So let me now look at each of these endpoints in a little bit more detail. So in this plot, we graphed the cumulative events per patient for the control group in blue and the BAT group in red for the primary composite endpoint. And you can see that looking at the rate ratio and the p-values, there are no statistically significant differences between the two groups. If you look at both of the components of the primary endpoint, on the left, cardiovascular mortality, on the right, heart failure morbidity, again, no statistically difference between the two groups. Now, in order to better understand the totality of the data from this very important trial, we looked at several other endpoints. Here we're starting with the hierarchical composite using the win ratio analysis. Now, why do we do this? In part, it's because cardiovascular mortality and heart failure morbidity as an endpoint only allowed about 40% of the patients to contribute to the endpoint. Less than half of the patients contribute to the endpoint. Using the win ratio, however, 100% of the patients contributed to the endpoint. And this has become the preferred endpoint for many recent trials that have already reported and a number that are currently being undertaken. So these are the 4-step components to this hierarchical composite. The composite itself was analyzed statistically using the Finkelstein-Schoenfeld method. And here is the results of the win ratio. The win ratio was 1.26, favoring the BAT. 26% more of the BAT group had wins compared to the control, and that's reached a nominal p-value of 0.04. If you look at the 3 components of this composite, cardiovascular mortality, heart failure morbidity, and quality of life, you can see that they're equally distributed. In other words, they each contributed to the endpoint in an equivalent manner. Now, if you change cardiovascular mortality to all-cause mortality, which is something that statisticians like Stuart Pocock have encouraged us to do, you can see that the results are basically the same. Okay, we also looked at a clinical stability analysis, which is using the same method as the investigators for Emperor Reduced used. These are the definitions on the left. On the right, you can see that patients treated with BAT had more frequent improvement and less frequent worsening than the control group. You can see the p-values and the proportional odd ratios. Okay, importantly here, the freedom from all-cause death LVAD or transplant is plotted here. BAT resulted in a 34% reduction in that relative risk, and the nominal p-value approached significance at 0.054. These are the actual individual data. Durability, the safety profile is very durable, meaning that over the entire conduct of the trial, the MANCE-free rate was about 97%. Remember, this is surgically implanted as an outpatient and totally extravascular. Okay, what about the symptomatic endpoints? Beginning with quality of life. For this and the next 2 slides, I'm plotting the change from baseline to the endpoint of 6 months, 12 months, and 24 months in the BAT group shown in red, the control group shown in blue, and the difference between the two in green. So pay most attention to the green bars. For each time period, there is a statistically significant large difference and improvement in quality of life in BAT versus control. Remember, the Minnesota Living with Heart Failure questionnaire, when the score falls, that's an improvement in quality of life. So you can see that this is durable over time and comparable in extent at each point. The same is true for exercise capacity measured by 6-minute hall walk. Here that's at 6 months and 12 months, durable in time and sustainable in effect. And lastly, improvement in functional heart class. Here we're measuring the change in New York Heart Association class by at least 1 class, and you can see that that happened significantly more frequently in BAT versus control. So when we come to a summary, despite the fact that the primary endpoint and its components were not statistically different between the two, We know that all-cause mortality, hierarchical win ratio favored BAT, as well as each of these measures of symptomatic improvement. Now, in the last couple of minutes, I think I have a couple of minutes here. In the last couple of minutes, I want to go over some details about the data in the first portion of this graph. What you can see here is, first, that none of these three measurements are statistically different between control and BAT. You can see where the 95% confidence intervals are. However, the question's been raised, is there a discordance between mortality, in which you're seeing the point estimate to the right of the line of unity favoring BAT, and the heart failure morbidity line to the left of the line of unity with not favoring BAT. And this has been brought up to me, I can't tell you how many times, by a number of investigators asking, why is there this discordance when this looks like it improves mortality? All these other factors are clearly favoring BAT. Why is this what was considered an outlier and discordant? So we thought about that, and let me return to this composite endpoint and point out to you, if you look at the time period from 1 year after randomization to about two years or 2.5 years after randomization, it looks as though the BAT group had a favorable response, and then that favorable response faded. The question is, why did that happen? And remembering my experience with the BeAT-HF study and the effect of COVID, we said, is there a COVID effect in this analysis? Here you can see that at 1 and 2 years, the difference between the two groups was noticeable. If you look at a COVID analysis, again, we used exactly the same method as was used in BeAT-HF, which I was the first author in the publication. And we highlighted here the number of years of follow-up during COVID. Now, we made an arbitrary decision that the most active time for COVID was the year 2020. Remember, this is an all US, basically a US study. So between January 2020 and January 2021, almost 24% of the patient follow-up occurred during that period of time. So we pursued that analysis. Now, again, I want to remind you, this is the way we looked at cumulative heart failure morbidity, in which we set every patient to the same time 0 at the time that the device was put in, and then looked at them at 1, 2, 3, and 4 years. If you take the same data, and you rearrange it so that you're looking at time, the dates that these events occurred on the horizontal axis, you start to see something which is truly remarkable. Look at what happens to the control. Again, this is the start of 2020, the end of 2020. And let me highlight that time period. You can see that the rate of events was chugging along at a constant rate in both groups, and suddenly something happened that was truly remarkable. The control group fell to a very, very low rate. The BAT group continued on. Now, this time period here for a couple of months, it looked as though the BAT group started to plateau, but that didn't continue for very long. So if you look at these data from the point of view of the specific time period, start on the bottom first. BAT's rate for heart failure morbidity was 0.26 for all years except 2020, when it rose just a speck. I mean, this is a numerical value, but it's not statistically significant, versus the control group that was 0.29 through all the years except 2020, which, I mean, came very close to 0. So we concluded from this that COVID definitely impacted the results of the study. It did it differentially between the control and the BAT group. Now, why that happened differentially, we're still investigating, and whether and to what extent COVID affected and limited our ability to identify a difference between BAT and control, specifically for heart failure morbidity, is going to await further analysis, but I'm going to give you one such analysis. So we looked at an interaction analysis between 2020 and all dates not 2020, and we specifically looked at the primary endpoint, the heart failure endpoint. I'm sorry, I labeled it wrong. This is the mortality endpoint, the heart failure endpoint, and then the composite. And in only the heart failure endpoint, and only during 2020 was this different, and the interaction p-value was very significant. So we said, what if you did an analysis in which you deleted the heart failure events just during 2020? What would happen to this analysis? So this is the analysis I showed you in the beginning. If you do this analysis without heart failure hospitalizations during 2020, look what happens. And I'll go back and forth over this a couple of times. So now you can see that the heart failure morbidity, now again, there are no statistically significant differences between BAT and control for any of these three measurements, but at least the point estimates now all fall on the right side, my right, but on the favoring BAT side of the line of unity. And I think that removes any notion of discordance between these events. I think there's basically enough data in this one analysis to say that there's concordance of data if you exclude the COVID effect. So I'm going to conclude with one statement, which is that we believe that the data that you've just seen, the totality of this evidence, indicates that BAT is safe, is effective, and is a durable treatment for patients with heart failure and a reduced ejection fraction. And I'm going to stop the presentation here and be happy to answer any questions. And I'm going to stop sharing here.
Thank you very much for these two excellent presentations. And clearly the result of the BeAT-HF study was not as expected. And I think we had, like in other studies like the GUIDE-HF or also the AFFIRM study, we had an impact of COVID, and you did already and are doing a lot to decipher what really happens. And do we have questions from the floor?
Thank you so much for the talk. I guess it's most important for patients to have an improvement in quality of life, and this is what the study has shown to us. I guess your patient group was mostly ischemic heart disease, as like 65% were with CADR. My question is, which kind of cardiomyopathy do you have the most benefit? Does a DCM or a non-ischemic heart disease profit?
So in the first phase of BeAT-HF, we actually looked at each of the patient characteristics. We looked at ischemic versus non-ischemic, AFib versus non-AFib, male versus female, and several other of the demographic features. And it turns out that the symptomatic improvement was equivalent in each of the subgroups. So the short answer to your question is, we believe that patients with ischemic etiology for HFrEF and patients with non-ischemic etiology for HFrEF have an equivalent benefit.
And maybe a second question regarding to this: what is your opinion? Does this system will help patients with a hypertrophic cardiomyopathy as well?
Well, okay. So now you're going beyond the data which I can give you.
Well, you're the expert.
Yeah. So let's talk about hypertrophic cardiomyopathy in a couple of different ways. If you're talking about the genetic form of hypertrophic obstructive cardiomyopathy, I think we have to be a little bit careful. Many of those patients start out with a preserved ejection fraction. Many of those patients can go on to have a deterioration of systolic function. And sometimes when people use the word hypertrophic cardiomyopathy, they really mean hypertensive hypertrophy-induced heart failure, like is seen in HFpEF. I think I think I should not speculate just now on what the effect of BAT is on those groups of patients, except to say one thing. Everything that I know about autonomic modulation and everything I know about autonomic regulation of patients with heart failure suggests that it doesn't matter what the ejection fraction is, there is an increase in sympathetic tone and a decrease in parasympathetic tone. And since that's a fundamental underlying unifying mechanism in HF ref and HF mildly reduced and in HF preserved, I think there's a reasonable expectation that there will be similar effects in all patients with heart failure, regardless of the ejection fraction. However, we have to do a specific study to examine that. I don't think my speculation should be taken as an indication to place the device. But we as the executive steering committee and the sponsor CVRX have every hope that the next study we will do will be in all patients with heart failure above an ejection fraction of 35%. We're hoping to get started on that in the very near future.
We would expect that also in HFpEF the device will work, but we have to prove it.
Yeah. Agree.
We have another question, Dr. Halbach.
Thank you very much for the excellent talk. And I would be interested, how was the effect on blood pressure, and would you consider Barostim in patients with low blood pressure?
So that's a really fascinating question. And I'm going to go on for a couple of minutes. Bear with me because there's a bunch of information that I'd like to share with you. So when the surgeon places the baroreceptor stimulator on the carotid artery, we're actually using the acute effect in the operating room to determine the ideal location here. So we put the device here, we turn on the device, and we actually measure a decrease in blood pressure and a decrease in heart rate as an acute effect. What's fascinating, and then we turn the device off, we swap the patient, we take them out to the discharge room, discharge them home, bring them back, and on several occasions over a number of weeks, we bring them back to the study center, we activate the device until it reaches a symptomatic point where they feel a little bit of buzzing or a sensation here in the cutaneous space. And then we back off to just under where they feel that, bring them back in a couple of weeks and do it again. And over a 6-week period of time, you can get to the place that you want to go. And in each case, every time you activate this, it moves blood pressure down. But what you find is, as soon as you send them home on that new setting, their blood pressure rises back up again. And we have not seen anyone treated with this device who ends up hypotensive, back in the hospital with dizziness, lightheadedness, or syncope. And the question is, why don't we see a marked decrease in blood pressure over the longer period of time? The best data that I know, and it's very small, so I don't want to bang too hard on the podium here, but we actually think that stroke volume probably goes up. And as you know, if stroke volume goes up, pressure tends to go up. And actually, if you look at pulse pressure, it tends to widen a bit. So we think that chronically, there actually may be an improvement in pulse pressure and because of an improvement in stroke volume. I don't have chapter and verse on that. That's in a specific sub-study. But that's what we think happens as long as, and we have not seen, even in blood pressure as low as 90 systolic, we haven't seen people tumble down into a hypotensive state. They tolerate this very, very well, and are have a marked improvement in symptom status. So we don't see a marked reduction in blood pressure, even in patients who are marginal at 100 or 95 or 90 over the long term. Now, remember that this is a device that's individualizable. You can dial in the amount of BAT that you want, and that's important. These patients develop other clinical syndromes. We've had people who have come down with COVID and were septic or had other things like that, in which their blood pressure went down for non-cardiovascular reasons, you can back off on the BAT so that doesn't contribute to a clinical complication. So the fact that you can dial up and you can dial down is unique and important. And remember that once you turn this on, the patient never has to think about it again, do they? So the compliance factor for these patients, as opposed to what we struggle with in terms of drug application, is very different. Turn it on, it's gone. The patient never has to think about it again.
For elucidating on this, because it's very important, because we have during heart failure treatment, we don't have problems with hypotension, but it's also a device you can use for refractory hypertension. We will have a case later on that. So, but I compare it often also to the ACE inhibitor. When we started ACE inhibition, this was also tens of years ago, it was a hypotensive drug. It was labeled for hypertension primarily, but in patients with heart failure, when we start at a rather low blood pressure, we can bring in the ACE inhibitor, we can increase the dosages, and in several of these patients, then the blood pressure goes up because we improve function of the left ventricle, we have better cardiac output, and then blood pressure goes up. So this is perhaps a comparison. It's not directly related, but we have this experience also in heart failure. Yeah.
Yeah, I would like to draw the attention a little bit that we are looking here in a device therapy for heart failure, and I would like you to comment perhaps shortly on the excellent safety profile, as well as on perhaps different timelines for the different ejection fraction situations for the event rate that we may be seeing. So if you alluded that the therapy may work both in patients below 35% ejection fraction and above. We talked about remodeling effects that may be also involved, stroke volume improvements, which also actually make the patient more tolerant to higher doses of the Fantastic Four of Johannes Spausachs. So I think could you highlight a little bit what would be your expectations when we see an effectiveness? If we looked at the data in the first talk on SGLT2, we saw that the effectiveness was there somewhere between 30 and 60 days. So typically within the first 2 months, we see first effectiveness. On valvular and on iron, on structural heart interventions, in these patients, we typically see response time after 3 months to 12 months, so a little bit later. So if we look into the Ironman trial, for instance, depletion of iron, the maximum effects begin at 4 months, for instance. So could you highlight a little bit on this and perhaps on the timeline for future studies? BeAT-HF had the majority actually enrolled in the first part, 60 only afterwards. Do we need more in order to get the hard endpoints like outcome into a significant phase? Do we just have to enroll BeAT-HF 3? Those would be 3 questions in one.
And you wanted me to do a short answer here. So
we're excellent in time. We're excellent in the time frame.
So the data I can tell you is we've looked at ejection fractions between 25 and 35 and below 25. And the effect is the same over that ejection fraction range. I don't want to speculate as to whether, what that would do in terms of higher ejection fractions. I think we have to study that. But just within and think about this compared to contractility, cardiac contractility modulation, where they saw better effects between 25 and 35. We didn't see any lower boundary cutoff. All I can tell you is that that's present. I don't want to harp on that too hard, but there is slight difference there. Now, in terms of when the effect occurs, there's 2 crossing issues here. One is it takes a little bit of time to titrate this drug up. And I don't think we can make this a little shorter. We were trying to do this in a very careful way. Given that it's the carotid artery, we were very concerned about neurologic effects. And we wanted to make absolutely sure that we didn't impose any kind of persistent neurologic effects. And that's why our titration was kind of slow to begin with, and it takes a few weeks to get there. So you don't even get to the maximum amount until you get to the maximum amount. So if you look at the data that I showed you on the primary endpoint, you can see that there's not much separation for the first year, but a substantial portion of that year is up titration. So in some of our centers, particularly there's one in Columbia, South Carolina, our investigator who's put in 40 of these in his patients, we've worked with him to sort of decrease the titration period from something like 3 months to something like about 6 weeks. And it appears we can do that safely without having any other off-target effects. So I think just like Greg Fonarow keeps telling us that we need to give all the medicines all at once, all at the highest dose, and everybody will be okay, which I think we could do a better job at. I think your point is the sooner we get the target dose of this device, the sooner we'll start to derive benefit. I don't want to speculate too much about data that I don't have, but the data that I do have says that separation between the two groups really starts around, just about 9 months to a year. You asked one other question, which, how soon are we going to get to another study?
Exactly, the third cohort.
Yeah. Well, first of all, let me answer the other question, which is, did we have a sufficient number of patients here to get to the endpoint that we were looking for, or was this underpowered? Well, you guys both know, the audience both knows, everybody in the audience knows that you can't do a 6,000 patient study here. It just doesn't work with devices. But what we think as an executive committee, I'm only speaking from the point of view of the academic steering committee, what we think the next study should look like is all ejection fractions greater than 35, all implanted. So we don't have to deal with the non-implanted control, all implanted, blinded for 1 year, and perhaps maybe a little bit longer, but let's start with 1 year. And we would also like to pay special attention to people with hypertensive heart disease as the cause of their heart failure syndrome, and also look to see in those patients with relatively refractory hypertension whether their blood pressure comes down. So none of this has been written down yet. None of this has been proposed. You asked me, how am I thinking about this? That's how I'm thinking about this. I don't think the sponsor has any commitment to this, but I think it's logical to expect that would be the next kind of trial that we would do.
This, just one sentence, with this you would have the sham control and a crossover possibility. If you just had the devices off for 1 year and you would switch the groups, this would actually alleviate all your control situations. The difference, you would have a sham control in one moment, you could keep in half of the patients the device off for 1 year and then activate it. That would be one suggestion from an outside activist in structural heart failure. Thank you.
And we hope that there won't be another pandemic or a 9/11 or nuclear war or some other catastrophe to mess up our analysis.
It was great discussing with you. Thanks for joining this session and enjoy the rest of the weekend. Bye-bye.